Hi, my name is Alexis Fitzpatrick, and I would like to share with you a very important issue that is very dear to my heart and hopefully will be dear to yours and lend your support. When seeking medical care, there are standards of service that patients expect from their healthcare providers. The healthcare providers that treat them are trained to give them the care that rises to the standard that has been set. The standards for the quality of care should apply to all patients, including those that have medical conditions that require their course of treatment to be altered. Sadly, the standards of medical care are not altered to effectively treat those that have ongoing medical conditions or medical conditions that are never changing and not termed to be in a remissive or stasis state. The problem is one that is not recognized among healthcare providers due to no existing precedent and lack of training. The patients that suffer from these ongoing conditions are forced to undergo treatment plans that were put into place for patients that do not suffer from ongoing conditions. While there are many ongoing conditions that are recognized, patients that have suffered third-degree full-depth burns are not included in this category at the present time. These patients have had to undergo rigorous treatment when the initial injury occurs. To treat injuries of this type, the decimated skin has to be replaced with grafted skin. The skin to be grafted is taken from either a site on the patient where healthy skin remains or grown for them in a laboratory. While this process has advanced in leaps and bounds over the years, the fact still remains that once the grafted skin is healed, it changes and does not stretch or grow with the patient. When treating patients with this condition, medical personnel need to be aware of these significant differences. Unfortunately, a large amount of the time, this does not happen. This big problem calls for a big solution. Healthcare providers need to have additional training across the board regarding the treatment of patients with skin grafts and how their body's reactions differ greatly from those that haven't been burned. And healthcare providers need to set up a new set of guidelines for prescribing pain medications to patients that have been treated for this type of trauma. In addition, patients should be given a copy of their complete medical history stored on a flash drive or other comparable digital form, which they can keep with them to assist their current doctor in treating them more effectively. To better understand the enormity of this problem, the differences between grafted skin and normal skin must be understood. Grafted skin is not like normal skin in that it does not stretch or grow with the patient. A patient that has had skin grafts while they were still a child will have to have additional grafts as they grow to permit full mobility. Grafted skin also reacts very differently to incisions and topical ointments that are normally used in various treatments, and these reactions can change as frequently as every month. For these reasons, patients that have grafted skin are considered to have an ongoing medical condition. The first issue with this problem is that medical personnel need additional training to teach them how to care for grafted skin. The secondary issue is that the healthcare provider needs to keep in mind that the patient has had to undergo many painful procedures that warranted the use of painkillers in doses that are not normally given. This causes the patient to have a higher tolerance to painkillers than that of a normal individual. Physicians need to keep this in mind when prescribing pain medication for these patients. The doses that are normally given will most likely not be effective for a person who has been given so many painkillers in the past. A full thickness burn destroys the first two layers of skin, and therefore the ability of the skin in that location to regenerate. Advances in Skin and Wound Care, 2005. In addition to the grafted skin lacking the ability to stretch, it can change in sensitivity, color, and texture in a matter of months. While normal skin has none of these problems associated with treating ailments that affect it, grafted skin, however, does. When a surgeon makes an incision in healthy skin, they can predict with a great deal of certainty how the healthy skin will react when it's cut. This is not the case with grafted skin. A good analogy to envision what will occur when the grafted skin is cut is to picture what happens when you hold a cotton bed sheet tightly and cut it. The result will be that the sheet will split much further down than the length of the actual cut due to how tightly it is being held in place. The grafted skin does not have the elasticity like that of normal skin. As a result of this, when the patient grows, it is necessary for more grafts to accommodate for the lack of elasticity. Another property of the grafted skin is that it is very sensitive to topical ointments as well. With the grafted skin considered an ongoing condition, its sensitivity can vary from month to month. Split-thickness skin grafts and full-thickness create a deficiency in the skin which can take years to heal. Arden, Danielson, Jorgensen, Karlsmark, 2013. The initial treatment of burn victims varies greatly from other medical treatments. Therefore, the after and long-term care for victims should be altered as well due to the trauma that their body has been through. Medical personnel are given the minimum amount of training required to pass their exams, but unless they work in a burn unit or perform reconstructive plastic surgery, they lack the training to properly care for a patient with this type of condition effectively. Without being able to view a patient's medical history in its entirety, they often make the wrong judgment call when treating them. For instance, say you have a 34-year-old male that comes into the emergency room who suspects he has shingles. The only problem with diagnosis is that the physician does not have access to the patient's full medical history and has no frame of reference as to what the patient's grafted skin looks like when there is no irritation present. When Stephen Fitzpatrick was 9 years old, 7 kids set him on fire outside his apartment complex in Cuyahoga Falls, Ohio. When he caught on fire, he was enveloped. His mind went into shock, and he began to run. 2 parking lots away, a man saw something on fire and looked closer to see what it was. When he realized that it was a person, he ran the length of the 2 parking lots, grabbed Stephen, and put out the fire. Stephen was taken to the burn center at Akron Children's Hospital. He was burned on 73% of his body. He spent 4 months at the burn center recuperating from the 3rd-degree full tissue burns. The hospital grew 44 squares of skin for him. At one point during the process of all the grafts needed, he was considered 100% skinless. For 2 of the 4 months, Stephen was in a drug-induced coma to allow all of the grafts to heal properly. Patients like Stephen should not be treated like those that have not lived through a horrific event such as this. There are those that run the insurance companies and write the policies for hospitals and doctors' offices, who believe that patients that have skin grafts should have to follow the same course of treatment as those that have not been burned. The basis for this thinking is that they are wanting to ensure that everyone receives the same standard of care. The World Health Organization says that, formalized in 1948, the Universal Declaration of Human Rights recognizes the inherent dignity and the equal and unalienable rights of all members of the human family. Paragraph 1, 2014. They would argue that to ensure all the patients receive the same standard of care, all patients should undergo the same course of treatment. This statement is not true for all patients, due to the fact that if the patient has suffered 3rd-degree full-thickness burns and had to have grafted skin, they need to be treated differently. So, by treating them the same, they are actually ensuring that they will not get the standard of care that the organization is striving to provide. The solution to this problem is many-faceted. Teaching seminars need to be implemented for emergency room doctors and for primary care physicians. This training should be implemented and mandatory for all healthcare professionals and given by a specially trained individual that has had first-hand experience dealing with these burn victims. These training sessions should be offered at several times and in several locations, and be offered free of charge. They should also cover how to best prescribe pain medication to burn victims. The patients themselves should be given a full, detailed copy of their medical history so that the doctor treating them can see how they have reacted to certain courses of treatment in the past. This will allow the doctor to see how high the patient's pain tolerance is to the painkillers and how any topical ointments have also affected them previously. Implementation of all these elements combined should ensure that the burn victim receives the care that treats their current ailments in the most effective manner the first time.